Log on, tune in, find out. Another good idea from Cambridge.
Okay, so we don't have much time. Let's go to the second speaker today, which is Delingette from Bordeaux. He's going to talk about personalizations or electromechanical models of the heart. Please.
Thank you. So I'd like to first start thanking the organizer for inviting me, and just point out that I'm not in Bordeaux. I'm staying in at the Asclepios team in Sophia Antipolis, next to Nice, in France. So I'll be talking about the personalization of biophysical model, and especially the personalization of cardiac models. And I will start my lecture, by introducing the different terms of models and also personalization. So in this lecture, a model, a biophysical model, is a mathematical representation of a human body and eventually its pathologies. And it encompasses fairly different representations. So it can be, I would say the term model is usually taken in a very ambiguous manner. So in many cases, it is understood as being a geometric model or geometric representation. And of course, this is one important part of biophysical models. And this is those models, the geometrical models, they are usually reconstructed from medical images through image segmentations, for instance. This is an example here of reconstruction of a brain and skulls from MRI. But it can also be a model of the appearance. So what you see in this image, for instance, is the different appearance of a structure, of a glioblastoma actually, in MR sequences. So you have different MR sequences, T1 weighted, T2, etc., fractional anisotropy. And you can see that this structure appears differently, and you can also try to model those different appearances. You have also the physical model. So in this case, you are modeling the way for instance, in this case, the mechanics of a structure. So this is you may have recognized a floating lever, which is being deformed interactively in the context of surgery simulations. So in this case, you are interested in representing the biomechanics of a structure. And if you go one level further, you can also go towards the physiological model. So in this case, you are modeling the interactions of different structures or different organs. You can also model the physiopathology. So in this case, the growth of a tumor in the brain, a glioblastoma in the brain. So this is like the highest level of models that you could imagine. And those different models, so starting from, again, shape to physics to physiology, they have different objectives. So, for instance, basically a model can have an objective is to represent what is being observed in images. So this is what I call a descriptive model or a phenomenological model. So typically this could be used for image analysis, serving as a prior term. We have seen in the previous presentation regularization and the data fidelity term. So models can be used, for instance, models of mechanics can be used to regularize image registration. It could be used, these descriptive models could be used for teaching anatomy, physiology. It could be used for training in the context, for instance, of surgery simulation. So in this case, what matters is that it looks right. It's not that it's really based on the right physical and physiological principles. The second type of model is the discriminative models. In this case, again, it may not be based on the right principle, but what matters is that it can discriminate one population against another, or it can discriminate the presence of a pathology. So this could be used definitely for diagnosis. So diagnosing, for instance, the presence of a tumor, or patient selections for therapy. For instance, in case of cardiac, you want to select the patient that are suitable for inserting a pacemaker. It can be used also as a biomarker in clinical trials. So again, these models may not be exactly predicting correctly. It may be biased, but they can be used as discriminative models. And finally, the highest level of, I would say, models, or the model that require the most accuracy, is the predictive models. You want to predict the evolution of a pathology. You want to predict what would occur on the structure when I, for instance, perform surgery. It could also be used for drug discovery or developing new therapies. Now, the objective here is to couple those models with some images, or let's say in more general observations. It can be images or signals. And those signals also and images can be of various types. So you may start with very rich data, which have been acquired in the laboratory under control on animals, for instance. So it's usually very good to start with, because you have lots of information that you control, and you can already validate your model on this data. But it's very invasive, and at the end of the spectrum, you have the non-invasive data that has been acquired on patients. And of course, you have some intermediate cases where you do, for instance, invasive measurements of patients. For instance, when you measure electrophysiology in a patient, you need to insert a catheter, and this is definitely invasive. So the big picture is the following, is that you want to couple your models, so which can be of different nature, multi-scale eventually, with your images. And this coupling is what I call, in a generic way, a personalization. So you want your model somehow to match what you observe. And once you've done this, you can actually perform diagnosis, you can perform therapy planning or prevention. So this is basically what drives my presentation, is this big picture of personalization for diagnosis and therapy planning. So what do you actually personalize? So you can, as I said already, personalize the shape. So most of those models, they are relying on computational meshes, and those meshes can be extracted through image segmentation from images. But what is new here, I think a new concept, is also to personalize the state variable of your model. And in physics, you make a distinction between extensive variables and intensive variables. And by nature, it's what you observe usually is related to extensive variables, like cardiac motion. You can see that in a time series of images. You can image flow, an MRI. You can image the blood flow. But it's far difficult to actually observe something related to intensive variables like stress, pressure, and forces. So another way of saying that is that you can also estimate constitutive parameters, which are relating extensive and intensive variables, and also boundary conditions and initial value. So example is that you want to estimate with personalization stiffness, contractility, or porosity parameters. So now if I move away the issue of building computational meshes and concentrating on the personalization of those physiological models, this is not just fitting parameters to data. So it's definitely solving inverse problem. But to do this, you need to first to go through the sensitivity analysis. So you must assess what is the outcome of your simulation is sensitive to which parameters, and then provide a hierarchy of those parameters to know which one you should first estimate. The second issue, which is also key, is the observability. So if you observe from an image a cardiac motion, you can ask yourself, what parameters can I estimate from that? It's the observability. And in many cases, you cannot, you observe a combination of parameters, like a product or ratio of parameters, which means that you need to fix some of parameters and then to estimate some others. So you must set a strategy for this. Also, the fact that in this case, the parameters, they are related to physiology and physics. It means that they have a range of value which is constrained. You know that the stiffness of a myocardium is not the stiffness of concrete. So this must be taken into account. And finally, I think it's key also to design your model such that the complexity of a model is similar, matches the complexity of your observations. So if you observed very sparse measurements of your, let's say, electrophysiology, it may not be a good idea to try to fit a very complex electrophysiological model on those data sets. That's what I mean here. Now, the outcome of this personalization is not only a value of parameters or, let's say, initial conditions, but you can also go further from that. You want to also to have an estimation of a covariance, or let's say, some kind of confidence on your parameters. And you can even go further by having a posterior distribution of those probability distributions of those parameters. I think one point here I'd like to state is that doing this personalization, so if you have a model, you want to represent something that you observe. Actually, in many cases, you will find out that your model doesn't match really well with your observations. And in fact, this process helps you to understand the limits of your models. But on the other side, if it fits well the observation, doesn't mean that you have a validated model. So in some sense, you can only learn bad news with this process. You cannot have good news, because if you want to validate your model, you need to have some predictions. So your model must be able to predict some phenomena that has not been observed, and then check that this prediction match what you have, what occurs in reality. But if you are able to reproduce what you observe, it doesn't mean that you have a predictive model. So that's why it's I think, necessary step, but not sufficient to really go through the predictive models. So of course, there are some technical issues. Now is the occurrence of uncertainty. What you measure is you have noise, you have sparsity of the data. The fact that in many cases what you measure is also already the outcome of some computation, image processing, registration, segmentation, and which themselves has parameters. So those processes also include some new uncertainties. Of course, the model may be wrong, and in many cases it is wrong. And you may have also issues with discretization errors if you are using a mesh that are too coarse. In terms of methodology, we are dealing here in most of the cases with dynamic systems. So estimating parameters with dynamic system is not a simple issue. And you must use tools that has been developed in the context of filtering or control, optimal control. For instance, you can use optimal filtering or Kalman filtering. You can use also variational methods such as the adjoint method or stochastic PDs. So these are some of the tools that may be used, and I will illustrate some of those in my lecture. So now I've just given you some broad general scope of this work. Now I will focus on the issue of personalization of cardiac models. So this has been done in the scope of a different project at INRIA. So this is acknowledgement here from my colleagues, also from funding from different European projects. And so the modeling of a heart is a topic that is already 50 years old now. It started in the 60s at the University of Oxford with Professor Dennis Noble. And now there are many groups in the world trying to develop in silico models of a heart. And this is a multi-scale and multi-physics issue. And here I'm just citing some different approach, some different parts of the cardiac models that needs to be taken into account. So the anatomy, the electrophysiology, the mechanics, the blood flow, and the perfusion. And of course, all those phenomena are coupled with each other. So the objective of those models is to first better understand what is going on when the heart beats. Again, to try to integrate the different phenomena together, and also to estimate some invisible quantities from images. So again, what you have access in images is mostly shape and extensive, as I said, related to extensive variables of flow, motion. But you do not have access to stress, pressure, and so on. So you want to have to improve this knowledge by using those personalized models. And also you want to be able to predict the effect of therapy. And in our case, we are interested in cardiac resynchronization therapy and radiofrequency ablation. So this is just like a more down-to-earth application of this work. So this is, again, the big picture of this work. We have this basically cardiac models that I've already mentioned. You have a personalization stage. And once you have personalized your model, you can use them for therapy planning and diagnosis. Now I will go through very quickly the different aspects of those work. So in terms of anatomy, again, this is the business of applying image segmentation approaches, so to build computational meshes like those ones from MRI or CT. So I will not go into the details, but at the end, what we produce is volumetric meshes of the right and left ventricle. An important part is the fact that the heart is a muscle, and therefore it is it has cardiac fibers, which actually acts both in the electrophysiology and the mechanical function. Sorry. And actually, this was known for a long time, but now we have a new technique which is called diffusion tensor MRI, which allows us to actually have an insight about the microstructure of the heart. And this allows to have some knowledge about the fiber architecture in the heart. And we have recently built an atlas, actually the first atlas of a human fiber architecture based on 10 data sets, and where we were able to build an average representation of those fibers and also the viability of those fiber architecture, and to build also, so what you see here is just a representation of those atlases. So what you see here is just the way the fibers change across the myocardium wall, from the endocardium to the epicardium. And this is the outcome of this. So this is very important. Again, this is driving a lot of our the results that I'm going to show, because most of the propagation in the heart are anisotropic, both mechanically and also for the electrophysiology. So talking about electrophysiology, you know that, as I said, the heart is a muscle, is a pump that pumps blood in the general system. Now, but this pump is controlled by some signal, the electrical signals, and the signal starts from the sinus nodes and then propagates through the heart to again activate and deactivate the cardiac muscles. So this is what is shown here, and you have a general patterns of propagation of this wave. Now, when we model electrophysiology, we want to reproduce this depolarization wave and repolarization waves. And there are different ways of doing this. There is a whole literature on this. And in our case, we are using a very simple model. It's basically a reaction diffusion model. The diffusion here takes into account the anisotropy along the fibers. And this is the so-called Mitchell-Schaeffer model, which models basically U is the difference of potential. So this movie here shows the difference, the exchange of ions across the cardiac membrane. So this is the cardiac membrane, and along the cardiac cycle, you have an exchange of ions, which creates the difference of potentials. And this difference of potentials is captured by this reaction diffusion equation here. And importantly, that this equation is governed by 5 different parameters. The diffusion parameters and 4 constant parameters. And okay, this is an example of simulations on this Mitchell-Schaeffer model. Okay, but you can see here. So the color here represents the action potential. And now I'm moving to a brief description of a cardiac mechanics. So an important piece here is the coupling between the electrophysiology and the mechanics. And there has been different approaches, but we have developed with our colleagues at Rocancourt a compact model. This is basically different models. So you can recognize here U, which is the action potential shown previously, and now sigma C is the stress acting along the fiber direction. So when you have this signal that goes the change of potentials through the myocardium, this creates a tension along the fiber, which creates the contraction and then the relaxation of the heart. And this is inspired from the Huxley filament model, and to derive those equations, we use statistical mechanics to go from nanoscopic models to macroscopic models. And I will skip the details, but this is what you can achieve at the end when you integrate the electrophysiology with a mechanical model. We have also a model of the passive behavior of the heart, which is a viscoelastic material. We use here nonlinear mechanics. And we take into account also the 4 cardiac phases, and especially the fact that we have isovolumetric contraction and isovolumetric relaxation. So if I slow down the simulation, you can see the relationship between the change of potential here with the contraction and followed by the relaxation of the cardiac fibers, okay? Contraction, relaxation, okay? So the link between electrophysiology and mechanics. And okay, just in a concrete manner, with our current implementation, it takes on the order of 45 minutes to simulate 1 cardiac cycle. On this type of, we use linear tetrahedra as finite elements here. Okay, and now, okay, I'm going to talk mostly about the personalization issue here, and therefore solving inverse problems. How do we tackle this in the case of cardiac models? So again, I just recall the issue here. So we have observations both in terms of electrophysiology signals and in terms of time series of cardiac images. So we have electrophysiological models. How can we make sure that the two agrees that the model is properly coupled with images? So we do this by first doing electrophysiology personalization followed by a mechanics personalization. Okay, now, so for the electrophysiology, we take into account some very rich data. This is, you can see that ex vivo heart, which is a porcine heart, which is being perfused, and where a dye has been injected to reveal the change of intensity as a function of, change of intensity as a function of action potential. So you can see in this movie, maybe. Okay, yeah, the image here, there are 2 cameras looking at the scene that can observe the change of potential. We take into account the anatomy of a heart as well. And then we can try to personalize. So on the right-hand side, you can see, so this is the observations. And this is the model if you do not perform any personalization. So you can see that the wave here, so the color here corresponds to depicts again the action potential. You can see that there is no agreement between these two. Okay, I must say that in this case we stimulate the heart at the apex of the right ventricle, so at this stage here. So here this corresponds to where you stimulate the signals, and if you don't set the parameters correctly, you see that there's no agreement. But after you personalize, you can match these 2 images and can see that you have now a fairly good agreement between these 2. Okay. And in this case, we were even able to predict the propagation of signals on the heart. So in this case, we change the way we stimulate. We stimulate now at the apex of the left ventricle, and without changing anything, we were able to predict correctly the propagation wave with some errors, but which was limited. So here we estimate some parameters.
Which ones?
Well, I'm going to talk about that, yeah. So actually 3 parameters.
Is this the Mihaela Pop experiment?
Yes, yeah. Yes, you're probably well aware of that. So this can be also done on in vivo measurements. This was done at King's College London. Previously it was done at the Sunnybrook Health Science Centre in Toronto. And in the case of a human heart, the data is not of as good quality. So we insert a catheter inside the heart to measure electrodes that are touching the heart and then measuring the potential. So the quality of data is not as good. But okay, now going back to the models, I just want to recall that we have 5 parameters. So diffusion coefficients and 4 time constants. Now, how do we match the different parameters? So in the case of human data sets, the input data is a map of depolarization times and action potential duration. And we have also, we know that the heart, those action potential duration changes depending on the frequency at which you stimulate the heart. So this is called also restitution curves, but I won't be talking about this too much. I just want to mention how we did this personalization quickly. And so first we did a sensitivity analysis. So we looked at which was dependent on the deposition times. We know that this is dependent on both the diffusion parameter, the diffusivity parameter, as well as the tau-in parameter. And for action potential duration, it includes this. If we also include several frequencies, this is a bit more complex. But because we are using a very simple, so this is very useful to know which parameter will fit to which experiments. And because we're using a simple model, we were able to have some closed form relationship between, for instance, action potential duration and the parameters. In this case, you have this action potential in 1D. You can establish with this very simple model that APD is related to this. And this is we'll use this to actually estimate some of those parameters. Also for the diffusivity parameter, we first do a rough calibration of the parameters to initialize the value. So we establish some very rough relationship between C, the conduction velocity, and D, the diffusivity parameters. And then we minimize the discrepancy between the deposition times, which is measured and simulated. And for this, we are using a fairly, I would say, brute force approach, which is to use a gradient-free method. So you don't need to estimate directly the derivative of this function with respect to each parameters. And so it's a trust region algorithm, and which we are able to converge. So it requires several forward simulations, but in a reasonable amount of time, we are able to estimate the diffusivity parameters. And we have also a strategy to divide the different regions where the diffusivity coefficients are defined. So this is the outcome of this on the case of human data sets. So you can see now that the diffusion parameters vary spatially, but the tau clause related to APD also varies spatially. Okay? So this is what allows us to have a match between what you observe and what you simulate. And just to show here, this is again the observations, and this is what we simulate in terms of deposition times. So there are some discrepancy. I'd like to mention that the black part here corresponds to the scars, but the locations where you don't have any conductions, this is related to infarction. So infarcted tissue leads to areas of dead cells which do not conduct anymore. And so we have a reasonable, I would say, mean error in terms of deposition times. So this is the approach that was mostly used. I would like to mention also that there are another approach that was presented by Ender, I think on Tuesday, on using a more sophisticated approach, stochastic PDE, and also, in this case, we're not only interested in the parameters themselves, but also on the whole probability distributions. Okay, I will skip this because I'm running late. Just a few words about the mechanics personalization. Now, we've done the electrophysiology personalization. So from the measurements, we estimate some parameters. Now we have some cardiac images and time series of cardiac images. So you've seen this beating heart in the images. And then we want to estimate some mechanical parameters, such as the stiffness of a material or the contractility of the muscles. So how do we do this? So we first stage is to estimate the cardiac motion. So this is what I've put here. So we have the image. We need to produce some kind of a new estimate of the cardiac motion, because this is a necessary step to personalize the model. So there are many existing algorithms in the literature to do the tracking of a heart in images. And here we were saying that, and most of those approaches, they are again using regularization. So they are using, let's say, optical flow, and then this optical flow is being regularized by some prior. And we thought that we could use actually our electromechanical model to regularize this prior, if you want, to serve as prior in this case. So that's why we propose to use this electromechanical model to regularize the data. And therefore, this is like a new scheme where we generalize the approach of deformable models two proactive deformable models. Proactive because instead of having a static prior, which is not depending on time, now the prior itself depends on time. And the fact it depends on time is because we have this contraction and relaxation of the heart over time. So this is what we call this proactive deformable models. So now we have our dynamic system, which is the electromechanical model here, and where we add this image force, which drives the boundary of the heart to fit the apparent boundary in the image. That's basically the approach. And here I'd like to make a statement on the difference between regularization versus personalization. So again, we are coupling medical images with a model, and what you can do is first do, if you want to estimate the cardiac motion, is trust mostly the image and only use this model to regularize the data. Okay, so this is data regularization. So where you trust mostly what you have in the image. On the other hand, you can mostly trust the model and use the data to estimate the parameters of the model. So which is like a dual approach. Okay, and what we have been mostly doing in, I would say, medical imaging has been the regularization stage. Now, in this case, we try to use the symmetric approach, where we mostly trust the model and see if we can use this model to recover the motion on the image. Of course, what you get at the end is not the same thing. When you regularize the data, what you get is the cardiac motion, which is interesting in itself. In this case here, what you have done at the end is you have not only the cardiac motion, but you have also personalized the model. And this can be used further for the therapy planning. So the image forces, there's nothing magic here. We use this, we try to estimate the position after tracking. We use block matching here. We could have used a different other approach, optical flow or illustrations. But here we just, try to estimate the closest position for each vertex in the mesh. We try to find its closest position in the boundary of the image. And then we use this as a image forces. Okay, now this is a result of this. So we start with the electromechanical model without any image force. This is what you see in blue here, the blue curves. So of course this motion doesn't match the motion in the image. Now we add the image forces to, in this case, again, the model helps to regularize the apparent motion in the images. In this case, you get the red curves, red mesh, which definitely fits much better what you see. So this is a 3D representation where we have a short axis and long axis. And you can see that the red curves matches much better the cardiac motion seen in the image. Okay, now we've done this on other cases. Well, you can see that, again, we have not a perfect, but reasonable agreements. But again, this is after adding the image forces. Okay. Now, once we've done this, we have an idea. We know, we estimate how the heart beats in the images. The question is now, can we estimate the mechanical parameters, the contractility, stiffness, such that that corresponds to this to those observations. So in this case, we no longer use the image forces, but we want to find a new set of parameters, theta star, such that we minimize the functional, which is the discrepancy between the measured or estimated, I should say, displacement and the one that has been simulated. And very importantly is that you need to take into account the confidence in the measurements, especially because in computer vision there is a well-known aperture problem, which means that you cannot estimate the motion which is orthogonal to the apparent boundary. And this means that we should mostly rely on the orthogonal motion to estimate those parameters and not in the longitudinal motion. And there are, to solve this problem, so of estimating parameters from using a dynamic system, there are mostly two approaches. The first one is using filtering, or optimal filtering, and the most well-known approach is Kalman filtering. In our case, we have a nonlinear system So it means that we must use uncentered Kalman filtering or nonlinear, let's say, Kalman filtering. And the classical thing is that you increase the state variable with the parameters, and then you try to estimate the parameters, the initial value of these states. So the problem with Kalman filtering is that you must compute a covariance matrix whose of a full rank, so full size, which is not, and the size of this covariance matrix is the size of the states, which may be thousands, tens of thousands of nodes. It is a huge matrix, and therefore you cannot apply it easily on this type of problem of this size. That's why so our colleagues at INRIA, they have devised a new approach to use non-optimal filtering, so non-Kalman filtering. So they use this K matrix, the gain, which is not the one given by Kalman, but another one. But well, they were able to prove the convergence in the linear case, not in the nonlinear case, but which is easy to, I would say, easy to compute, and which can be with, I would say, low additional computational cost. So this is one way of doing that. Another way is to use variational approach, or in this case, the adjoint method. So in this case, you are minimizing the functional that I've already mentioned under the constraint that you have a relationship between the state of your model, which is given by this basic law of dynamics. So in fact, you have a minimization of your functional under the constraint that the state at time t+1 depends on the state at time t. And if you write this, so this includes Lagrange multiplier in your approach, and then the whole difficulty is to estimate those Lagrange multiplier. So in the adjoint method, you estimate those Lagrange multiplier, again using some backward recursive approach. So it means that at each, to estimate the gradient of your functional with respect to your parameters, you need to do a forward simulation followed by a backward simulation. And this allows to estimate PT, and later you can use PT, the Lagrange multiplier, to estimate the gradient of the error with respect to your parameters. And then you estimate the new parameters. So this is another approach. It is the one that we developed at Asclepios. And I'd like to show you some results of this. So what you see here is the outcome of the estimation of mechanical parameters. So in this case, we estimate contractility parameters, sigma 0. And you can see we use 8 iterations here. And we use a different value on the left ventricle. Sorry. We use a different value in the left ventricle, right ventricle, and at the scar region. Okay. And well, you can see that there is a reasonable agreement. It's not perfect, but it's already much better than it was before. And to verify, actually, this is more like for validation of our approach. We looked at the pressure curve. So the pressure was not used in the parameter estimation. Sorry. So the pressure was not used in the parameter estimation, but we were able to recover the pressure fairly well, at least in this stage of the cardiac cycle, not in the later stage, but in this first stage, we are able to recover fairly well the raise of pressure. So that's a way for us to try to validate this parameter estimation. And this was done also on 2 other cases. But in this case, this is a patient with dilated cardiomyopathy, and you see that the heart doesn't beat very much, which means that it's very hard actually for us to estimate any parameters given the very small contractions of a heart. Okay, now I'd like to conclude my lecture by some statements. I'd like to first state that it's very important to do this personalization, that you customize your model to your available observations. So you must first think very carefully about the model complexity that you use. Another statement, which is more general, is that there is a need in this community to compare the different models with each other. So each group have a different model, and obviously it would be necessary to compare the outcome of the different models together. Another important issue is to handle and propagate uncertainties. So it's quite surprising that most of the image processing algorithms, segmentation or registration, are interested in outputting, let's say, estimation of a displacement or estimation of a shape, but not the uncertainty related to the displacement and the shape. And in fact, it would be very important to generalize those approaches, because this uncertainty is very important for us to estimate the parameters, because there's uncertainty in the data must propagate into the uncertainty in the parameters. So this is a more general, I think, requirement in this for image processing, to also include a level of confidence in what is being computed. I'd like to state, of course, that personalization is difficult in those problems. There is an issue of parameters observability and data assimilation techniques. And this personalization, I think, is still very new for biophysical models. Of course, weather forecast, for instance, data assimilation has been used for 30 years. And now every weather forecast is based on mostly a variational approach. But for biophysical models, this is pretty new, and I think we need to really focus more on these topics. But I think it's very important to also to work on these topics to better understand what you measure and what you model. So this is basically would be the end of my presentation. Oops, sorry. And I will stop here.
So I may have missed it because it may be fast. What was the equations for the mechanical model where I can see the parameters?
Okay, yeah, I didn't show them. I showed the equations for the coupling, electrophysiological coupling. But for the mechanical model, so you have a passive, which is a passive hyperelastic model. So in this case, it was Mounier-Rivlin hyperelastic models. And then you add also viscosity on it. And then, the whole mechanical model is a rheological model. So you have in parallel, you have a passive model, and in parallel, you have a contractile element. So all this, and I should also say that we take into account some specific boundary conditions. So during the cardiac cycle, you have a phase where all the valves are closed, but the heart is still moving. In this case, you have an isovolumetric contraction or relaxation. And this is very important because during this phase, you have a raise of pressure. And if you want to have a fully, I would say, thermodynamically valid approach, you need to have your PV loop, like in an engine, where you have a raise of pressure with a constant volume, and so on. You must reproduce this. So our model that we propose includes automatically also those 4 cardiac cycles to represent the 4 phases of a cardiac cycle. So I don't know if so the parameters.
It's a program on inverse problems.
Right.
So if people would see, what's a good formulation of the inverse problem that they may be interested in. So in particular, so your data is matching it to the
motion.
Right, that force that you first estimate.
Right.
And from that one.
Yeah. Actually, but what I estimate here is the sigma 0. Okay, actually, I can show you here in the coupling equations. Okay, here. So, when I try to estimate, mechanical parameters. So I can either estimate, in this case, the passive parameters. So in this case, it will be the stiffness of the myocardium.
What are they, those equations?
But in this case, I estimate sigma c. Okay, sigma c, actually, not sigma c, sigma 0 here. This is the contractility. So it means that this is the active part. So when you have this electrophysiological information that arrives, this creates a contraction of a fiber. Okay, and now the rate of contraction, how much force it will produce, is controlled by this sigma 0 parameter here. So sigma c here is the stress along the fiber direction. And the amount of stress, to simplify, is governed by this sigma 0, which is the contractility.
Are these numbers or functions?
No, it's a number. Yeah, it's a.
So it's homogeneous over the heart.
No, it's not homogeneous. But that's why we took. It's a field, It's a field, but we have proposed here to estimate it in 3 regions: the right, left ventricle, and the scar region. You could also try to estimate everywhere, but you don't have enough data to estimate it correctly. You cannot observe it everywhere.
So you think of it as 3 numbers, basically.
Yeah, but we don't know if we could increase the number of regions, actually. Because classically the heart is being, I would say, represented as a 17 region, the left ventricle, So first we tried to estimate 17 numbers instead of 3, but then we found that we were not able to estimate them, or at least, let's say, they are not all observable. That's why we decreased drastically to 3, and where we could observe them. But then, of course, we would like to increase this number. It's still ongoing to have a strategy to increase the number of regions to estimate those parameters.
I think the concept for us of quantities that are observable or make a difference and are worth it. So that the inverse problem should make sense, should not any chief.
It's very nice connection. So is there any question? No more questions. Thanks, Sarah.